We will continue with our series of videos on dynamic tests in endocrinology. In this video, we will review the standard 2-day low-dose dexamethasone suppression test. Endocrinologists utilize this test to either confirm or refute equivocal screening tests, such as the 24-hour urinary-free cortisol, late-night salivary cortisol, or the 1 mg dexamethasone suppression test in patients suspected of having Cushing syndrome. So what are the pharmacologic properties of dexamethasone? Dexamethasone is the most potent exogenous glucocorticoid. Indeed, it is up to 15 times more potent than hydrocortisone. It exerts profound negative feedback inhibition of the hypothalamic pituitary adrenal axis. More importantly, it does not bind cortisol-binding globulin, a property that allows it to traverse the blood-brain barrier easily. Also, it has no cross-reactivity with hydrocortisone and its metabolites. As such, it is not measurable in the standard cortisol immunoassay. This makes it an ideal exogenous glucocorticoid for dynamic testing of the HPA axis. So what are the optimal testing conditions for this test? In preparing for the dexamethasone suppression test, estrogens, which increase corticosteroid-binding globulin, should be discontinued. This is because estrogens raise total cortisol and result in a falsely elevated post-suppression cortisol level. Indeed, random cortisol levels in patients on estrogen are artifactually high. This can result in these patients being inadvertently referred to an endocrinologist for evaluation of suspected Cushing syndrome. Also, medications that induce hepatic CYP3A4 may result in the rapid clearance of dexamethasone. As such, dexamethasone is unable to inhibit both ACTH and cortisol production. Post-suppression cortisol levels will therefore be inadvertently elevated due to impaired suppression of the HPA axis. This will lead to a diagnosis of endogenous hypercortisolemia even in normal patients without Cushing syndrome. Examples of medications associated with high false positive rate of the dexamethasone suppression test are anti-seizure medications, example phenobarbital, carbamazepine, and phenytoin. Additional medications include pioglitazone and rifampicin. For these reasons, it is reasonable to draw a concomitant dexamethasone level at the time of evaluation of post-suppression cortisol. In the case of rapid metabolism of dexamethasone, levels of dexamethasone would be very low, and this will clue you into knowing that the patient is likely on a medication that is interfering with the test. The material needed for the test is a single gold top tube. This should be labeled for the collection of both serum cortisol and dexamethasone exactly 6 hours after the last dose of dexamethasone. So how is the 2-day low-dose dexamethasone suppression test performed? The patient is instructed to take a 0.5 mg tablet of dexamethasone every 6 hours over a 2-day period. The classic dosing schedule involves taking dexamethasone at 8 a.m., 2 p.m., 8 p.m., and 2 a.m. The need to wake up during the normal sleep hours makes the schedule challenging for most patients. Consequently, some endocrinologists have a slightly altered dosing schedule, which involves taking the dexamethasone tablet at 6 a.m., 12 p.m., 6 p.m., and 12 a.m. for a total of 8 doses over a 2-day period. Both total cortisol and post-suppression dexamethasone levels are drawn exactly 6 hours after the last dose of dexamethasone. How is this test interpreted? It is worth noting that the 2 mg 2-day dexamethasone suppression test has a higher sensitivity and specificity for diagnosing endogenous hypercortisolemia compared to the 1 mg overnight dexamethasone suppression test. Post-suppression serum cortisol, which is greater than 1.4 to 1.8 micrograms per deciliter, is highly suggestive of Cushing's syndrome. Before we conclude, let's review the more commonly performed 1 mg dexamethasone suppression test. In the standard 1 mg dexamethasone suppression test, 1 mg of dexamethasone is administered around 11 p.m., followed by a sampling of serum cortisol by 8 a.m. the next morning. The rationale for choosing these time points is that by administering dexamethasone at 11 p.m., it can reach an appreciable plasma concentration needed to suppress endogenous ACTH production, which starts to be released around 3 a.m. and peaks around 7 to 8 a.m. I hope you found this video on the low-dose dexamethasone suppression test helpful. If you want to see more of our videos about endocrine pathophysiology, then hit the subscribe button. Do not forget to click the bell icon so you will be notified when future videos in endocrinology are uploaded. Thanks for watching.